Okay, we're going to get started for our next plenary session. It's a pleasure to introduce Dr. Van Gaal. Luc is professor of medicine at the University of Antwerp University in Belgium, in the Department of Endocrinology, Gynecology, and Metabolism. Over 500 papers, and I'll keep the introduction short, so we have plenty of time. Luc.
Thank you so much, Mr. Chairman, for this very kind introduction. I also would like to thank, with a thank within parentheses, John and Cyril, because they gave me the job to look into evidence, what kinds of nutrition and whether nutrition still remains important when we prescribe GLP-1s. And I have been digging the literature, but I changed the title, What Do We Know? And I think we still have to say that we don't know that much already. So these are my conflicts to disclose. And of course, we know that overweight and obesity is associated with multiple complications and comorbidities. And every day there is a new paper on something else that is being associated with. Why is it not moving?
I'll fix it, don't worry. Let's
Sorry, I was just looking to my screen
see.
here.
There we go.
Is that okay?
Beautiful.
These were the conflicts not interesting. So, and I was just mentioning that every day there is a new paper on a complication that is not expected to be associated with obesity, but it's there. So in the overall approach for treatment and for comprehensive treatment, we have to look to a multidisciplinary approach that may include new, very potent pharmacological agents, but please do not forget lifestyle intervention. This is what we speak about. It is GLP-1, and it was started at glucagon-like peptides 1, and in the treatment, we speak about a receptor agonist. Was developed for diabetes treatment with an excellent effect on glucose control. But meanwhile, as you all are aware, it has potent effects on eating behavior and body weight. It reduces blood pressure thanks to an increased natriuresis. It has anti-inflammatory properties. It helps to reduce coagulation and as such cardioprotective, renal protective. So it's a wonderful drug, as some people may claim. These are the different aspects that I wanted to share with you, somewhat longer than the others. Let's start with nutritional deficiencies in obesity. True for patients with type 2 diabetes, of course. And the majority of these deficiencies, vitamin D as most prevalent, folate, vitamin B12, low serum iron. And so if you look into different studies according to what population you look after, and the majority of these findings come from pre-screening for bariatric surgery, because bariatric surgery may lead to some more prominent deficiencies in vitamins and minerals. But please do not forget that we potentially have to do that as well in people with overweight and obesity who are not candidates for bariatric surgery. And if I refer to what Arne Astrup has published a number of years ago, International Journal, he mentioned that the people with overweight and obesity are overfed, but unfortunately undernourished. And if you compare a number of these vitamins in normal weight individuals, underweight and obese, then you will see that even the obesity shows some similar aspects in terms of a number of deficiencies. So I think for dietitians and for nutritionists that we should put focus on that aspect of a nutritional status before starting whatever kind of therapy. Is that important? Is that important for outcome? I just referred to a Taiwanese a paper that was published in PLOS ONE, and they looked into an aspect of nutritional index among a large group of 5,000 individuals with obesity, and where it turned out that in terms of outcome, the outcome was heart failure, hospitalization, and 1 year mortality, that those with the worst nutritional index, and that was based on measurements of albumin, that as these graphs will show you, that they were the worst for cardiovascular outcomes. So nutrition aspects, vitamin aspects, it remains important. How is GLP-1 working? I think you will know that there are a number of nutritional triggers that will help to release the GLP-1 from the L cells in the intro cells. And we know that there is not only a link with carbohydrate, but also fat and protein that may trigger the release of GLP-1, in addition to a number of paracrine effects. And if you look at the bottom to such a specific L cell, you will see that not only glucose, but also bile acids and fatty acids may play a triggering role in that mechanism by which GLP-1 is released. And you see there on the left panel that also sodium glucose transporter 1, not the 2, but the 1, seems to help in the release of this aspect as well. Do we know something about nutrition in GLP-1? Of course, there are many studies that have looked to that. I just picked up one because of the Mediterranean diet. Seems to be one of the most healthiest diets that we can imagine. And people with the Mediterranean diet apparently have a specific better GLP-1 secretion than other diets. And you can see that after 210 minutes after a load, that there is an increased GLP-1 release when you compare that to other approaches. Also oxyntomodulin, another gut hormone with some similar properties as GLP-1, seems to be increased after a food challenge as well. And in that respect, the Mediterranean diet, where we know that this has also beyond glucose effect on outcome, this is from a nutritional point of view an interesting aspect to look after. What do we know these days, mainly in the field of obesity? The same is true for diabetes, but in diabetes, the focus is merely on glucose control. It helps losing weight as well. But what do we know about the real efficacy? And I will show you 3 slides on the drugs. I start with semaglutide, which is just a GLP-1 receptor agonist. And as you see in the study that John Wilding and I was part of that paper published in the New England, that we will have, after a large year of observation, a close to 17% weight loss. And this was the first time, I think, that we can claim that such weight reduction could be observed in contrast to placebo. If we move to the next one, we have tirzepatide. Tirzepatide is a GIP and GLP-1 dual. It's one molecule, but with a dual agonistic effect. And I will not show you the weight loss of 22%, but I will show you that, as we did 10 to 15 years ago, claiming how many individuals were able to lose 10% of the body weight, of the initial weight. Nowadays, as you can see, we can speak about individuals losing 20% and 25% of the weight. And as you can see here, with the highest dose of tirzepatide, 63 and 40% respectively, that of the individuals that can reach that weight loss. And it's not finished yet. If we go to the 3 agonists, and I take the example of retatrutide, which is a triple hormonal receptor agonist, not only GLP-1 and GIP, but also glucagon, then you'll see, if you compare it here in that paper by Amy Jastreboff in the New England last year, that we will, mainly in women, go to 28.5% weight loss after roughly 1 year of observation. So if we put this a little bit in a perspective and trying to what has been looked for many years, trying to close the gap with what was possible with different bariatric approaches, you see liraglutide, the first injectable, 8% weight loss, semaglutide, 17%. tirzepatide 22, retatrutide 24, and there is also a heterogeneity. We know that with GLP-1, some individuals do not lose weight, others will lose 30 to 35% of body weight. We come very close to the results and the successes that we have seen with the bariatric surgery outcomes. So this not only shows closing the gap, but also shows the complexity of the treatment. What is the role of nutrition in this success? And I'm very happy that we have been able, together with the Belgian Association of Nutrition and the dietitians, to have a paper in order to sensitize our dietitians that they have to deliver good nutritional support, even for individuals who are treated with the drugs that have a very high weight loss successes. And as you can read, it's in Dutch, but levensstijlverandering, so the change in lifestyle remains essential, which was the message that Jolien, together with a number of dietitians, have put forward. So what is the role of nutrition? In the STEP trial, that was the trial with semaglutide 2.4 milligram in individuals without diabetes, with obesity, you saw that 17% weight loss. There was a nutritional approach, the classical ones that are given, which is a reduction of roughly 500 kilocalories per day with stimulation of physical exercise, roughly 150 minutes of exercise per week. And if we then compare that to the right panel, which is just a very nice paper that Donna Ryan published a few weeks ago in Nature Medicine, which is part of the SELECT trial. This was also a trial with semaglutide, same dose, 2.4 milligram, with slightly lower BMI levels in that individuals, but that was a trial, a cardiovascular outcome trial with individuals who had a pre-existing cardiovascular disease. Was mainly driven by cardiologists. I don't have any problem with cardiologists, but there was no nutritional support, not at all. Not foreseen in the protocol, and you will see that there is a difference, 17% after 1 year in step 1 with a nutritional support, 10%, it was there after 1 year, it was luckily nice persistent, but it was only 10%. And then you can say, yeah, but the BMI was slightly different. Yeah, if you look down to the details that Donna Ryan published in their Nature paper, you will see that for the BMI, the weight loss, except for the lower category, but the weight loss was the same BMI 30 to 35, 35 to 40, or even 40. So what we can say that about that is, in general, the benefits of a healthy lifestyle on top of what GLP-1 may offer, that in the majority of the protocols, GLP-1 receptor agonists are labeled as adjunct to lifestyle. But this is not done in the diabetes trials. It is not done in the cardiovascular outcome trials. And that counseling and that advice was delivered by dietitian with repetitive visits or by qualified healthcare professionals. And usually, as I mentioned, a moderate calorie deficit and exercise was advised. And even in some cases, in order to intensify the situation, there was a recording of the diet and an activation using a diary or a smartphone. But again, a little bit difference between step 1 and SELECT. The primary outcome of these trials was different. In SELECT, it was the primary outcome was weight loss, whereas in SELECT, it was a cardiovascular outcome with the classical 3-point MACE, as you know. So it's a difference. Is this enough to claim that the dietitian and the dietary approach is important? I'm in favor of that, but there is no, it's not a head-to-head comparison, so that's a problem. Is intensive lifestyle important? And then I refer to what I would call the signature of the Tom Wadden papers and the Tom Wadden designs that he has done years ago already with orlistat. He has done that with many drugs. And you will see that in this trial, initially, he started in the design of this trial also with semaglutide 2.4 milligram with an intensive lifestyle. 30 sessions instead of 17 sessions that the individuals received in step. But if you look at, despite that intensified a higher exercise, follow-up, telephone calls, etc., that instead of that initial intensive weight loss, at the end, after 68 weeks, it was also around 16 to 17% weight loss, and the numbers and the number of individuals that were able to lose 20 kilos or 20% was comparable to what we have seen in step one. So you could argue maybe nutritional support and certainly intensive lifestyle is in terms of outcome not so important, but we come back to that later. So what kind of lifestyle should we then foresee if we have to advise individuals? And I would advise and advocate to do so even if they receive these days intensified and very powerful drugs. In that respect, we have to think, I believe, beyond calories, as was also published in an obesity review paper, because many aspects will have, and many components of what we eat will not only lead to an increased energy expended, but the energy that comes in is greater than what is expended, and this may lead to a cardiometabolic risk. In that respect, we have to look also to another aspect that is in this field of overweight and obesity important, which is snacking versus craving. And if you believe what is written there by Marangoni, that snacking may be beneficial, certainly when it is planned, as you may read, it can contribute to improve the overall diet quality. It may reduce the risk of overweight and obesity, but this is snacking. In contrast to craving. And food craving is very often associated with dietary intake and metabolic health, and food craving predicts the consumption of highly palatable foods. So that is important. And that, as was suggested here in this paper, the findings of significant associations of food cravings is associated with lower diet quality, poor eating patterns, and unfavorable body composition. This conclusion was published in Appetite. And if we speak about appetite, if you read the side effects of the GLP-1 receptor agonists, you will see beyond the classical gastrointestinal side effects that appetite reduction is also a complication. And this means that some people are going to eat less at the 3 meals that they classically have to eat throughout the day, but that they may, in a compensatory way, going to snacking. And this is, of course, a bad attitude, because that snacking and that craving may lead to a bad quality of food and to unhealthy aspects. John Blundell performed a beautiful study with semaglutide, where I advise you to read that. It was published in Diabetes, Obesity, and Metabolism, where he questioned in a number of questionnaires about food craving, about how they feel. As you can read, how strong have any food cravings been on average? How often have you eaten in response to food craving, etc. And you will see that the majority of these attitudes are in favor of the use of a GLP-1 receptor agonist, such as semaglutides. And a recent paper that was published a few months ago in the International Journal of Obesity by Bataduba also concluded that the changes in the food preferences and the ingestive behaviors after glucocorticoid analogs, that this may give you a number of additional parameters that can contribute with the anti-obesity studies, and then they conclude and suggest that for further studies that more attention to the mechanisms how the GLP-1 may lead to these different food preferences may be implicated. In a general approach for how nutrition should be planned and advocated to people under GLP-1 was just published by Volek, who indicate here, it brings us later to the aspect of protein, that consuming 1.2 to 2 grams of protein per kilogram of reference weight is a reasonable target for most adults undergoing major weight loss. It's very sensitive, this one. That protein doses should be distributed evenly across the day versus a skewed approach, and that, of course, the protein content should be of high biological value. Next point. Is there any concern about lean mass? You may become aware that the social media are full of messages that people are losing lean mass with GLP-1, that they have muscle loss, etc. So what is true? If we look, this is the example of tirzepatide. People losing weight lose in the majority of cases, as you can see in the left panel, close to 34% is loss of fat mass, but there always is also a little bit of lean mass that is lost. And as the authors in this body composition with DEXA approach concluded, that participants on tirzepatide had a 3 times greater % reduction in fat mass than lean mass, but resulting in an overall improvement in body composition. The question is, what do we know and what do we exactly know about lean body mass? What do we mean with lean body mass? Because lean body mass is not muscle only. It's also a bone, it's water that people are losing in the initial approach with weight reduction. How is it measured? And we know that DEXA is a potential reliable approach. BI is much less reliable. How is it interpreted? And then the important point, we discussed that already an hour ago, the difference between lean mass changes, what is referred to in social media, and muscle volume and muscle functionality. If you write on the right panel is the example of liraglutide, where was in the majority fat mass loss, also a little bit of lean mass loss. But at the end, if you compare it in a ratio, you will see that at the end of the study, after the liraglutide treatment, that 53% was lean mass at baseline, and this increased to 56% at the end. So the question is, do we look to lean mass separately, or do we consider that as a ratio of the total weight? And as you can see on the left panel, there are a number of studies that clearly indicate that associations of fat mass and muscle function, that not lean mass, but that it is the functionality that is important in this case, in this study for cognitive impairment. A recent analysis, it was published in the International Journal of Obesity recently, where Alexia Biku published a systematic review on the effect of semaglutide on lean mass. And as you can read the result, it were 6 studies in 1,500 individuals that have been analyzed. While the lean mass remained stable in some cases, notable reductions ranging from 0 to 40% of total weight reduction were observed, but noteworthy decreases in lean mass were particularly in larger trials, and yet the proportion of lean mass relative to total body mass increased, suggesting an overall outcome. The question is this true? Can we rely on that? Yes or no? And then there is a short trial. It was based on BI, so I think this is very limited, where a powder protein was added, 1.5 gram per kilogram normalized body weight on average was an addition of 92.5 kilogram, and then lean body mass was not significantly changed between the control group on one hand and the lean mass. So whether protein addition is really important is still an open question. On the other way, as I mentioned before, this is an older study from Rondanelli, who have looked into sarcopenic people with overweight, that the use of protein, amino acids, and vitamin D supplementation together with physical activity could increase the fat-free mass and mainly the strength and the functionality, and leading to increased quality and increases quality of life. I think this is important because we will see mainly from cardiologists after the nice results and the significant results on cardiovascular outcome, we will see more elderly individuals with pre-existing cardiovascular disease who are a little bit at the limit of having frailty, being potentially sarcopenic individuals, and then it may be true to consider an optimal protein intake. This is adapted from Lady and was also already in the study group recommendations included. And I think mainly the last point, whether you go from 1.2 to 1.5 kilogram per gram per kilogram per weight per day is recommended. I think that mainly in people over the age of 65, that they may require higher protein intakes. Is another aspect in what we would could advise to individuals with overweight and obesity is extra fiber needed. I think it is important for a number of good outcomes, because mixed fiber interventions may have beneficial effects in showing the cardiometabolic benefits. And as mentioned in yellow there, total dietary fiber should be more than 25 grams per day for women and more than 30 grams per day in men, and even slightly more in people with diabetes. Is there some special diets that we may advise? Would we advise time-restricted eating, whether we consider alternate day fasting, 5.2 diet, time-restricted eating, intermittent fasting? I refer to what I found is that mainly on the short term, you see that intermittent fasting, time-restricted eating is advised to be safe, to have nice effects on cardiometabolic parameters, but there are not that many long-term studies. There is one study, it was a retrospective analysis from a Swedish study with a large number of individuals who had a large follow-up and were mainly in women who continuously received a low carbohydrate, high protein diet, showed an increased mortality, and mainly mortality from cardiovascular disease, up to 20% increase, mainly in women. So these are aspects, I think, that still has to be considered, whether this is safe for people with type 2 diabetes and obesity. I advise you to read a nice paper that was published also recently from Jorge Martinez, who tried to put together the clinical recommendations from a nutritional point of view in terms of the gastrointestinal side effects that we observe with GLP-1. And you know, it's mainly nausea, vomiting, diarrhea, constipation, and then they give advice limiting alcohol intake, drinking a lot of water. So the aspect of hydration is another important aspect, avoiding fat meals, avoiding spicy food. So this is a nice paper that I advise you to read. And if there is a persistent aspect of nausea and vomiting, they give advice to a number of extra advices. Do we see some, if we speak about side effects, is there any evidence whether the side effects, nausea and vomiting, may explain the outcome? I refer to Mike Lean's paper from a number of years ago with liraglutide, and Wharton's paper more recently with semaglutide, where you see that for those who were showing the highest gastrointestinal side effects, only in the highest doses and with the majority, the highest weight loss, that there is a slight tendency to have explanations for the association between the side effects and the outcome. Finally, a few of future considerations. We know this is an analysis that we performed together with John Wilding when the semaglutide after the step 1 trial was stopped, and you will see that there is a regain of body weight. So I think it is from a nutritional, from a lifestyle approach important to have something in hand to help these patients for whatever reason they stop with the GLP-1. You'll see even in those who had the most prominent weight loss of over 25%, that they regained weight when the drug was stopped. And there was at the ADA a few days ago, there was a session that specifically looked to that, and you will see a number of guidelines and tricks that they provided to help patients to prevent the weight gain after stopping of GLP-1s. And the dietitians at that session were exploring how a certified diabetes care and education specialist can help optimize the outcomes of GLP-1 based therapies. And these are a number of aspects that she was putting forward. Finally, I mentioned already the aspect of intensive lifestyle, and I showed in the Tom Wadden paper that it did not make that big difference. However, with the most recent paper with tirzepatide that he also published last year in Nature Medicine, where he started with a VLCD period prior to the administration, so prior to the administration of GLP-1. And I know this is discussed, and we recently had discussions about whether this is a good approach, whether we should wait to prescribe a GLP-1 after we have an initiation of a VLCD. This still remains open, but here it gives an additional 5 to 10% weight loss. However, in this Tom Wadden paper, the individuals who did not lose the 5% weight loss during the VLCD introduction, they could not be randomized. So we never will know what the effects will be of the GLP-1 for those who were bad responders. And the final point I wanted to comment on is that I think physical exercise should also be taken into consideration. There's a very nice paper from Lundgren a few years ago. This still was with liraglutide, that if you combine the weight loss that you observed with liraglutide, and this was not the most pronounced one, it was around 8 to 10%, but in combination with exercise, that you will see that there was mainly 4 aspects of cardiovascular fitness, which is, I think, also important in terms of outcome, is also beneficial. So the combination of GLP-1 plus physical exercise, probably even more important than diet intervention, is another aspect that still has to be questioned. We don't know the final answer. I will skip a few final slides, but I just will advise you to look in this paper that also was published a few weeks ago from the group from Tom Wadden, again on the recent recommendations. And this is a nice cartoon that was published there. So the nutritional assessment was there during treatment with anti-obesity medication, monitoring the response, advice on the recommended intakes, and then we see again fluid, protein, and dietary fiber together with micronutrients. So again, the early screen for vitamin deficiencies is also taken up again in this overall approach. I just would like to finish by saying that since we know that GLP-1 in a very recent paper have shown also extremely benefits in terms of kidney prevention and kidney damage prevention, and if you look to the KDIGO guidelines that was just recently published, you will see there that in all the drugs that we can give to these individuals, patients with diabetes will have kidney disease, exercise, nutrition, and smoking cessation is at the basis of this overall approach. And finally, please read the paper of Christina Lewis, where she published game changes do new medications make lifestyle-based treatment of obesity obsolete. And she concluded that, of course, that the two approaches still remain complementary and must coexist if we are to make a significant difference on a population basis. And I thank you for your attention.
I think we'll conclude, and Dr. Bennett will be available for questions at the break.